Welcome to the Sustainable Clinical Medicine Podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hi, everybody, and welcome back. So I brought in Dr. Adam Harrison today. So inside the Charting Champions program, I try and bring in an expert guest coach every month. And I came across Adam's profile in LinkedIn when I was looking for ideas for guest coaches. And what appealed to me first was gender, because I have a lot of female physician coaches up my sleeve. But at that time, I really didn't have a pool of dudes to call on. And so when I saw Adam's profile, and at that time he was in Australia, which I thought was very cool as well, I thought, well, it's nice to connect with these new people in my life and figure out who they are and what they do, what population are they serving, and how could that help my members. So that is how we started getting connected. And I learned all about Adam's area of expertise, which for the most part, when we first connected, was around bullying. And that victim piece that a lot of physicians experience within their clinical environment and clinical day. So, or you might hear yourself thinking, I work with toxic people, or I have a toxic person in my life. So that's kind of where I had started learning about what Adam can offer to physicians. And then he has also branched out into other things. So Adam, welcome, and I'll let you introduce yourself.
Hi, Sarah. Thanks so much for having me. It's a real privilege to be on your show. Thank you. Yeah, gosh, where to start? It's been a very, very circuitous journey, as you know. So doctor by trade, doctor by training, graduated in 2000, went down the surgical training route initially, so sort of surgical residency. Some things happened along the way that made me realize that maybe I didn't want to be an attending surgeon, and I maybe wanted a bit more autonomy, and not to be working within the British National Health Service structure. Mm-hmm. So I then segued into family medicine training, did my residency in that, had a challenging time within that, actually. Definitely burnt out as a family medicine trainee, and then as a junior attending in family medicine. Had always had an enduring interest in medical law, and this seemed to me the right time to explore that, and an opportunity arose, and I went to work for a medical legal organization for a couple of years. Decided that was very interesting, but not fully satisfying, and that I was a bit frustrated handing the interesting cases over to the lawyers. I was like, I want to do that, like a lot of doctors, bit of a completer finisher. So trained to be a lawyer. So did that as well. Went to law school, passed the bar in 2014. And then that kind of coincided with our first child being very small. She was 14 months at that time, and my wife's an attending maxillofacial surgeon, and she was a resident at the time. And it was just a bit like, oh, am I going to go off and be a trainee lawyer, in a firm, and never be at home and never see my baby, and how's that going to kind of work out with my wife's career and all of this. And she was on a really established training pathway, mm-hmm. and she was heading to the attending as the goal. So I was like, well, you're more kind of sorted than I am. It doesn't make sense for me to kind of disrupt everything within the family, to go off and be a very junior lawyer, and kind of financial implications of all of that as well, as you can imagine. So I'll just I'll figure it out. I'll I'm dual qualified. I'll be okay. You carry on doing what you're doing. I can be around a bit to, do a bit more of the childcare and things like that. So that's what I did. I reached out to a few organizations locally and explained that, I was a qualified family physician and qualified lawyer now, and this is my skill set. This is things I could offer them. Got picked up by a couple of organizations locally, and then my medical leadership journey began. So I ended up being an assistant medical director for a fairly large region near where I live, responsible for the sort of discipline and regulation side of things for family doctors and dentists. And I also was kind of doing advisory work for a local medical committee, and I ended up being the medical director of an urgent treatment centre. So that's kind of, and all the while I was managing to, maintain a bit of clinical practice. To be fair, I wasn't much more interested in all the other stuff, but I kind of carried on doing a bit of clinical. I had medical students there to tutor and residents to supervise. So that was cool. I love that kind of, satisfied the educator side of me. But yeah, so ultimately, before we moved to Australia, as you said, which we don't live there now, that was for my wife's fellowship. I was in a couple of medical leadership roles. I was doing a bit of clinical work. I was doing some educator stuff and just doing some general consultancy stuff, and just loving it. Absolutely loving what we call here in the UK a portfolio career. And I was thriving on it. But the law of another year out, because I had a gap year before university, but I don't know if you call them that there, but we call them gap years in the UK. And so, like, being a middle-aged person and being able to have another gap year, was like, wow, it's just too irresistible an offer to turn down, right? And as you can see, the Northern Territory is in the background of my Zoom. So and then things changed. I had experienced some coaching. I'd had leadership coaching in one of my leadership roles. Absolutely loved that. That was, sounds cheesy, but it's not an understatement to say it was life-changing. And so I decided that while my wife was kind of busy working in a maxillofacial fellowship and the girls were at school, I was going to train to be a coach. So I did my life leadership and executive coaching training in Australia. And then, when we eventually got back to the UK, I set myself up, and that's what I'm doing now, coaching and training doctors and in healthcare organizations. So sorry, it was a bit of a lengthy introduction, but you did ask.
So I'm going to pull out of there. So you had mentioned about coming out of surgical training, not enjoying that loss of autonomy. So can you explain what was unsustainable about the clinical experience you were having then? So what was that looking like? Because you really did, you said exit strategy because you're on a training program. And so exiting a training program, we know that's hard, right? You're on a path. And so saying, no, thank you, and going somewhere else must have been something. If you're happy to go there, tell us what that looked like for you.
Yeah, very, very happy to share this. So I did a succession of different surgical jobs, and I think this is where there's a slight departure from the system in the US. Before you become a registrar, which is like a senior resident equivalent, I would say, in your final chosen specialty, you spend several years being a junior resident in going around multiple specialties, and the exams that you have to do, they encompass all of those different areas. So even if you have never done an ENT job, there will still be questions on ENT things in the exam, for example. So I kind of moved into cardiothoracic surgery, orthopedics and trauma, general and breast, peds. And these were each for 6 months. And every job I did, I think it's, on reflection, I think it's because I was a fairly confident person, and it became very apparent to me many years later when I had my leadership training that one of my core values is justice, and there's also kind of fairness and equity that kind of run through me. Is that I couldn't stand to see the way that the bosses were treating us, and also, and so not just me, but my colleagues, and some of my colleagues were a bit less confident than I was. And so if I saw things that represented unfairness, inequity, a lack of parity, or just, downright bullying, I tended to have to speak up about it. And that obviously leads you getting a bit of a target on your back if you put your head above the parapet. So I was kind of courting trouble, really. But I it's just part of who I am, and if I had to do it all over again, I'd do the same. I just can't stand it, and especially colleagues who were maybe international medical graduates, who were experiencing more of that, or female colleagues and so on, kind of experiencing more of that, because surgical disciplines are pretty notorious for this kind of thing going on. So yeah, I mean, I would speak up and call stuff out, and I had everything from the very overt workplace bullying, the kind of berating, belittling, shaming, being shouted at on a ward round in front of a big entourage of about 12 different multidisciplinary colleagues, and not just fellow medics, in a bay of 4 patients, the consultant, that's what we call them in the UK, the attending, not giving, cardiac surgeon, not giving 2 hoots about the fact that he was pretty much embarrassing himself, in front of his own patients. It was, things like that, to the more sort of covert, over monitoring of your work, kind of creating a bit of a dossier of things that had gone wrong, and then calling you into the office to kind of like run through everything with you and give you a dressing down, kind of the usual kind of undermining, gaslighting stuff. And it's just every single surgical job that I moved on to, there seemed to be someone who would kind of single me out. And I just thought, this is not sustainable, and I also kind of, to be fair, I did also look around at the attendings. I remember very clearly, there was one who I got along very, very well with, and we were in the kind of the OR coffee room waiting for, the patient to be in the OR and us ready to start. And he got a phone call from some really, really junior administration person, really junior, basically saying, yeah, we've added in an extra clinic for you on such and such a day. And my boss was like, well, I can't do that then. And then, well, you don't have any choice, you have to do it. And it's just kind of like, you get to what you think is the top of the tree, medically, and yet you're still kind of subject to, and this is the autonomy piece for me, you're still subject to the, some middle manager basically handing it down to an 18-year-old to kind of phone you up and say you're doing an extra clinic and you don't have any choice about it, sort of thing. And I was like, nah, I don't think this is for me. And also there was a lot of infighting between the attendings, and I was like, yeah, in 7 years time or so, I'm going to be their immediate colleague. I don't really fancy that. So there were quite a few things that kind of were red flags, I suppose.
Yeah. Okay. So what I'd noticed is, one, you're experiencing this firsthand as a junior, and then you're looking ahead saying this continues even when I become a senior. And even with me speaking up, advocating for my peers, advocating for my juniors, I'm not changing the system. And as I get there, the final piece is, if nothing else, I want my, my autonomy around my schedule, and I won't even have that. So at that point, you're like, I wouldn't choose to stay with this partnership. You're like, this is not safe for me, I'm leaving. Yeah. Okay, so we see the attempts at every level to intervene within your micro culture. Do you think you made any impact in the micro culture? Like for those people that you were working with, who maybe the IMGs or the women physicians, or even yourself, who was on the receiving end of this, do you think there was any kind of satisfaction that I made a difference, I could on that level?
It's hard to say at the time, and we're looking back, really, gosh, I mean, 19 years ago that I did that first surgical junior resident job,
Yeah.
And I think that, on an individual basis, my efforts were appreciated. I think the big tension for the female trainees was, and I always forget to mention this, I'm a podcaster too, and you've been on my show, so I'm a podcaster, but now your audience does. But there's one of the people that I interviewed, kind of said that as a female trainee, you just have to work so much harder. You just have to be the absolute best to kind of compete with your male peers who are not as good as you, essentially. And so where I was perhaps offering some of my female colleagues that opportunity to be supported, there was also that little bit of pushback, I suppose, that no, I don't want anyone to stand up for me. I need to do this myself. And okay, I'm crying in the corner, but I've just got to push through this. And I've got to show them that they're not going to intimidate me. And I think that is something that they had to do for themselves. But I was, very young and sort of naive about things and didn't really appreciate that at the time. But, I tried. I did my best at the time.
Yeah. Okay. All right. So then moving forward, so then you said that you have these positions of leadership. You're already doing the medical administrative leadership position, and then you added coaching in, and it was life-changing. So I find that term kind of speaks to something that you weren't aware of happened within that training or within that experience of having a coaching experience. Tell us what is life-changing. So that it's very hard to kind of just put that term out there and not kind of give us the plain language of that experience. So what did that do to you? What were the things you learned, the lessons you learned, the impact from that? The before and after.
Yeah, I mean, again, kind of, if you look at sort of through my career, and after surgery, I went into family medicine, and that I really, really struggled with the demands that were put upon us as family medicine residents, mainly by the patients. I worked in a very deprived inner city area, and I definitely burnt out a couple of times, between 2000 and 2009. And it was only really, I suppose, when I got into that leadership role and I had that coaching, and for the first time in my life, I was asked to do an exercise about my values. And I'd never sort of stopped to think about that in the preceding 42 years of my life. And I'd never given any time to that side of my personal or professional development. You're just kind of getting on with life, aren't you? Just kind of like cracking on, firefighting, keeping your head above water, and having time to think about your values, that's a luxury, right? But when you're forced to do it by a coach, otherwise you're not going to have that assessment done by the next session, you do it. Oh, well, I do anyway. I find the accountability part of coaching so helpful. And and it was then that it struck me, things like justice, gratitude, humor, honesty, kindness, fairness, all of these things that kind of comprise my core values. It's like, oh my God, now when I look back, I realize why I stood up for those people when I was a junior doctor. I realized why I had this inescapable urge to scratch that itch of studying the law and training to become a lawyer, because justice is one of my top 5 core values. And we all know what our core values are, sort of inherently. We know, our moral compass is there, and our antennae are kind of pricking up if we're in alignment with things, or if something is, not in line with our integrity, and it's kind of, we're recoiling in horror. We know the kind of extremes of how our values work, but this was kind of fine print stuff, and it was just really, really eye-opening, a real kind of epiphany. And it was like, yes. And since that day forward, I have tried, and I don't always succeed by any stretch, but I try to live by my core values.
Mm-hmm.
And the work that I've done more recently in the last few years definitely reflects that.
Okay. So when you were in family medicine, and you're saying it was the patients and the way or how they interacted with you or their requests of you that led to burnout, where do you think that compromise on the core values was? What was happening there that was possibly adding to that?
You see, I'm, love and humor are two of my core values.
Mm-hmm.
And you know me, we like to have a laugh. I like to be, quite lighthearted, when it's appropriate. And I was just, and often I would have that kind of, I would invest emotionally in my patients, and I would, have a bit of fun with them when it seemed appropriate, and you know what it's like. Some patients are more up for that than others, and you choose carefully. And it was, so I got joy out of my work initially,
Mm-hmm.
but when patients are kind of coming in and you have 10-minute appointments, and they're coming in with a list of 10 things, and you notice over the years that they're getting more and more patients are becoming like that. They're becoming more demanding. Their expectations are higher in a broken system,
Mm-hmm.
where the workforce is diminishing, on a weekly basis. So the expectations are kind of running inversely proportional to what you can actually realistically satisfy.
Mm-hmm.
It becomes really tough then, and you don't have the time to kind of have that humor, have that banter, have those kind of like, touching emotional moments, because it's just, you just got to crack on and get on to the next patient, And I think one of the key features of burnout that I noticed was that sort of disengagement and that loss of empathy.
Mm-hmm.
And that was really upsetting for me, when I realized what was going on, because that was the bit I enjoyed the best about being a family doc,
Okay.
So, yeah.
So now if we swing that past your urgent care that you're a medical director of, what is it that you look out for in leadership that can help the people on the ground who are seeing patients and have this demand of, there's a full waiting room out there, and you've got X number of minutes, or we're going to be here all night with this next patient. Now what?
Yeah.
How does that turn up in medical leadership then? How are you looking out for them? What do you do differently? How does that perspective come forward?
So I think the old approach is, okay, yes, we're all in it together, but we've all been through the crap, so we all have to go through the crap. And it's, it's character building, the phrase that I despise the most, and you just have to do it, because we all had to do it. And this is a sort of pervasive attitude in, among, I think I don't want to be sort of ageist or whatever, but I think generationally it's a bit of a, kind of older generations of doctors. And that's the, kind of, when I was an intern and a very junior resident, that was the kind of, those are the things that were being said to me, but then some people, because, some people learned in medicine, we don't get taught leadership formally. So what do a lot of us do? We look to our superiors, our seniors for, a nudge on how to behave. And so there's a lot of modeling going on. And so there are still people of my generation who are behaving like that. But, you can be like that. But then the people who are on the shop floor they're kind of getting a hard time from the patients, and then they're not getting any kind of empathy or kindness shown to them. There's the team is, everyone is just trying to just survive the shift. No one is thriving. It's just surviving. And you're in your own little silo, you know what it's like in family medicine, in clinics, in urgent care as well. You're just in your own little silo, just you and the patient. And I think for me, what I've learned over the last few years is, I'm much more about compassionate, servant, inclusive, relational leadership. And I kind of use the umbrella term kind leadership. And I think that if the team at least can just be so first of all, certainly no authoritarian command and control leaders, just kind leaders and kindness within the team. And I do talks on this. I talk about the health benefits, the mental and physical benefits of kindness in the workplace. And it's phenomenal, the studies that kind of show how good it is, how medically good it is for you to be kind and show kindness and be on the receiving end of kindness. But if we can all kind of rally around and support each other and just help out when we see someone struggling, and just check in and see how people are, and not that kind of, how are you, and then kind of walk on our way, but actually I'm actually going to dedicate 10 minutes to going and saying how are you, and be there to listen after I've asked that question. Then I just think, if you're all in it together, but you've all got each other's backs, and that you can turn to people for help without being judged or treated unkindly, then that makes all the difference, I think.
Okay, so it looks like helping the team to be kind with each other, and helping people not be as siloed, so kind of pulling them out of their silo and checking in with them. I guess that even that would change. Would that have, if you had that experience, do you think that would have been helpful when you're doing family med?
Well, yes. And actually, just taking a step back, when I mentioned that in one of my surgical jobs that I was overly monitored, which goes beyond sort of micromanagement. It's the kind of creating a dossier of things. So when you do something wrong as a junior, which we all do, in my mind, the best way to kind of for a boss to manage that is just at the time it happens, or very shortly thereafter, kind of take you aside to a kind of private place and just say, oh, I heard that this happened, what's your side of the story? How do you think it went? What could you have done better? This is my suggestion. Okay, let's see how, if you implement this, how what happens next time, and just kind of deal with these things as they come along, and then you don't make a big deal of them. But to not deal with any of them and to then present your trainee with a list of 15 things that over the preceding 3 months they've done wrong, in your opinion, is just having been on the receiving end of that, it's vile. I sat there with 3 attendings the other side of the desk, and thankfully one was an ally. But I dread to think that if one hadn't been an ally, how I would have felt. And I had tears streaming down my face. Guy in his late 20s.
Yeah, you can see how that is so destructive in terms of feedback. So when we look at feedback models for looking after our residents and students, medical educator hat back on, when we look at the studies, how do we help? How do we give difficult feedback? The number one things are that private space, like you mentioned, with a trusted and respected educator, right? So somebody who has your back, wants to help you learn from this experience, and is not doing it in a public forum. Then the receiving resident, the receiving student, gets the best value out of it. They're actually more likely to take that information, say, oh, I see how I can use this, or how this is not, just because I'm a bad person. It is simply that this is what happened, and this is how we, troubleshoot it for next time, or here's how we learn or grow from it, rather than here's the 15 reasons why you're a bad person, right? Or you're a bad physician, or you're a bad, and timely, like you said, like in the moment or soon after, as soon as possible, that kind of reflection piece, the ability with a trusted person who has your best interest in heart and wants to help you grow, and is in a private space where you can actually take the time to process things. Yeah, that's what the evidence says is the best way to give feedback. The best way to actually get some change happening about these encounters. Rather than here's your laundry list of badness.
Yeah, exactly. And it's obviously important to follow the evidence space, but it doesn't take anything more than common sense to just realize that a kind approach is the best approach, right?
Treating ourselves, treating each other as human beings, right? Yeah. Did you know there was going to be a laundry list experience as part of your feedback?
No, and this wasn't, in a kind of a formal, appraisal or professional development review setting or anything like that. It was a completely random meeting that I was called to, and so I had no idea that was going to be, thrown at me. So
they're the sorts of experiences that we don't want to model in medicine.
Absolutely, which did put me off proceeding with surgical training. And but to be fair, the same or something very similar happened when I was a sort of fairly newly qualified family physician, and I was doing a maternity locum, and I was working at this practice, 0.7 FTE, in lieu of the doctor who was on maternity leave. And it was, there was a one of the partners there who was what I like to call a smiling assassin. So very nice to your face and smiley to your face, but really horrible behind your back. And him and the senior partner decided to kind of do something very similar. And again, no forewarning. But so it's really sad to say, but those experiences and my work in medico-legal circles, where I worked more with doctors, kind of looking after doctors, have kind of shown me that we know the administration can be challenging, and other colleagues can be challenging, nursing colleagues and other colleagues. But some of the people that you really have to watch out for the most are your own medical colleagues. And it's really a shame to say that. So
this is a good lessons in how not to do feedback. Right. And how to potentially, as senior physicians or as people within the medical education space, just noticing what that does to a human, right? So you have a surgical registrar who leaves. You have a family medicine doctor who leaves based on this level of irresponsibility with regards to feedback.
But toxic irresponsibility.
Toxic irresponsibility. How not to do feedback. And in these, and this is it, is that I found that working within those, I suppose there are two different systems. I suppose there's an overarching National Health Service system, but really family medicine and hospital work are quite different systems. But the same problems happening within both of those kind of pushed me away. And now, internationally, we're facing a medical workforce shortage crisis.
and with opportunities in other parts of the globe that are very appealing. You know, a lot of British doctors kind of looking to Australia, New Zealand, Canada, and they don't need much of a push for it to just make it that deciding factor that, okay, you know what, I'm not going to stay in this system. I'll go somewhere where, you know, I might be a little bit better treated. The money will probably be better, but hey, I'll have some sunshine as well. So yeah, so we need to be very, very careful if we want to make clinical medicine a sustainable career for the next generation. There has to be a paradigm shift with the way that we treat our juniors.
Yeah. And like you said, the system was broken. The cultures weren't great, but your own peers or your own positions above you, like your supervisors, they could have shown up differently and better to improve the immediate environment and psychological safety for you. I think this is an important lesson when we're looking at sustainable clinical medicine. Look at who is under your care umbrella. So your medical students, your residents, your peers, and how we're treating each other. Like you said, that kindness piece, bringing that back into. And so we know, as we look at the trauma-informed coaching lens, that when we are dealing with traumatized, burnt out physicians, they may show up looking like they're argumentative, short-tempered, obstructive, disruptive. So we know sometimes when we're showing up in that way, it's because we are hurt or hurting. So keep that in mind as we're interacting with our peers, but where possible, bring kindness. Where possible, giving our feedback in a way that is safe, creating that safety for our learners, creating safety for our peers. The number of times in my career where I've had a colleague be there when something bad happens, just to be there with you, so valuable, right? Kind of the opposite of what you had. Instead of the inquisition, it was the take the next hour off, go, you know, do the things you need to do. It's like, yes, it's what I need right now. And when we show that kindness, you can speak volumes to that person who just showed up for you in that moment, right? Which is what you're doing within that urgent care. You're like, I can't fix a number of people in the waiting room. I can't fix it. It feels like 5-minute medicine, but I can show up and give you kindness from above. And how are you and how can I help? Right?
Don't whatever you do the thing that I've seen, especially I've seen this sadly, you know, from female doctors to other female colleagues and IMG doctors to other IMG colleagues of, well, you know, I've been through it, so you have to go through it. And then they breach the glass ceiling, but then they pull the trapdoor up once they've got there. And it's like, sorry, there's no easy entry for you guys. You just have to go through the same crap that I went through. No. As you say, you know, just really provide that space, really listen. You know, I have to say that my listening skills have improved a lot since coaching, actually, and that's, you know, one of the absolutely beautiful things about it, and you know, why I see a lot of troubled colleagues really benefit from coaching, because so on the first times they've had, especially a fellow physician coach, they've had a fellow physician actually listen to them for the first time.
All right. So any things we haven't spoken about, tips, tricks for people listening who are trying to create a sustainable clinical medicine experience for themselves? Anything you've had that we didn't touch on?
So portfolio career we've talked about, kindness we've talked about. I mean, I think it for me, the whole portfolio thing enabled me to achieve a level of work-life balance that being in purely clinical medicine didn't allow. So, and that is so important, you know, without self-care and kind of like showing yourself some love, you know, it just has a knock-on effect on everything, you know, your self-worth, your self-confidence, you know, all of these things kind of come from that. You know, the kindness piece is just, it just makes you feel good as well. Okay, we don't do it for selfish reasons, we don't do it for that, but it as a knock-on effect, as well as being good for your own health, being kind to others, it's just good juju, isn't it? Really, let's face it, it's just pleasant, it's lovely, you know. And you know, again, going back to the values, I think it's so important to live, love, and lead by your values, and do work in alignment with your values. So you know, you may be working in a unit or a department or even an entire organization where the values are just either they're not the way they're purported to be. So organizations have these organizational values, right? And you know, you're looking for a job in a new corporate healthcare structure, and you go, oh wow, they've got kindness and understanding and fairness and, you know, and equity and all of this, and then you actually start working there and you realize it's all baloney. But you were drawn to those values because they're in alignment with your own values, and then you're triggered because those are not the real values. You know, or the values of your colleagues or your bosses, you know, are not in alignment with yours. So it's hard because you can never know what people's values are until you start working with them, right? But it creates a bit of an uphill struggle to try and work with people who are not on the same page as you, really, with regard to your values. And I just think be compassionate to yourself. You know, we know that we should be compassionate to others. We know, you know, our patients and our colleagues, but oftentimes we're just not. Where's the self-compassion? It's just not there.
Be kind to others and be kind to yourself. Love it.
Yeah, for sure. So and good. It just makes work so much more pleasurable and hence more sustainable.
Love it. Okay, so where can people find you, Adam, if they're looking to find out more?
Yeah, so I have a website, www.dradamharrison, so dradamharrison, all as one word.com. I mainly hang out on LinkedIn, as you know. So I'm just Dr. Adam Harrison on LinkedIn. And I have a YouTube channel as well, but my podcast is Inspiring Women Leaders, and I recommend that people check out your episode as a minimum, because it was great. But yeah, please, if you want to learn about great leadership from some utterly incredible women, then yeah, check out Inspiring Women Leaders, please.
Perfect. Thank you so much for coming on the podcast. I really appreciate your time. Bye.
My pleasure. Thanks for having me. Bye-bye.
All right. And last words, Adam. Let's hear them.
So I have a mantra that I use for my clients who have experienced workplace bullying. And I just think it's so important for them to know that they're not alone. It's not their fault. And they have no reason to feel ashamed, because a lot of us think we're alone when we're going through it, and we blame ourselves, and we don't want to talk about it because we feel shame. And you know, none of those are true. So please remember that.
Thank you so much. All right, have a good day, everybody. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the Premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.